use this mic if it's better? Because they're saying they can't hear you properly.
I'm not hearing properly. All right. Thank you. Is that mangled on purpose, or is this? All right, is it better? Okay. All right, so here's the mass actually. Here is the mass that we are talking about. And there is this, what looks like a dots, right? Spicules. What are these? Do you guys know? Should know a lot more than the boys, that's for sure, These are microcalcification, exactly. So this is actually one of the clues that someone may have actually a malignant diagnosis when they do a mammography. Of course, they do the mammography to screen for breast cancer. In this case, it is happening the other way around, right? I mean, the patient already have a mass, and she's doing actually the X-ray after finding out that the mass is there. You can see that the mass, one thing that you can say, about the mass borders in radiology, is that it looks irregular, right? It does look irregular. Is that good or bad? That's pretty bad, right? All right, we'll find out why is that bad. So she underwent a modified radical mastectomy. In yesteryears, it used to be that they will take the whole breast out. They will take muscles from the, from the chest wall, and they will take also the axillary, lymph nodes on that side. Now, after a lot of, clinical data accumulated and showed them that, less aggressive, more conservative kind of therapy may give actually the same results. We started to see the modified kind of operations. In this case, taking out the breast and also the axillary lymph node with it. And here is actually the mass that we are talking about. All right, so these are the borders of the mass. What could you tell me about this mass in general? It's what, I'm sorry? The regular border, okay, very good. This is one. Darker in color, okay. Yeah, so this is what this, what is this? Fat, exactly. So this is fat, and this is the mass right here. So the mass is in the fat, right? Right there, in the growth. So invading the fat, really, that's, where does the irregular borders come from?
The irregular growth, yeah, the irregular growth of cells, like because they're not all growing at the same rate.
Okay, no, not really. What else? All right, so let's talk about the counter, the other extreme, which is the benign tumor. This is a little early, but we can talk about this. So benign tumor usually, grows as an expansile mass. So it has a capsule surrounding it, and it grows by pushing actually and compressing the nearby tissue, expanding, right? But a malignant tumor grows by actually sending cells in nearby tissue, by sending tongues of cells in nearby tissue. Now, these tongues of cells are what create the irregular border, okay? So in your opinion, which is gonna be easier to shell out? Is it a benign tumor? Right, benign tumor, because it would have either a true capsule that grows with the tumor itself, or actually a capsule that resulted from the compression of nearby tissue, creating what is known as a pseudo capsule. Either way, it is encapsulated, and you can take it out in one piece, right? Will you be able to do that with a malignant tumor? No. Why? Because you have this shell. So how would you take it out with a malignant tumor? You may take part of what? Right, so you need to actually create what, your friend is absolutely on target. You need to actually take out what you call margin of resection from the nearby tissue, from the nearby apparent normal tissue. Okay, to make sure, and then is that it? You're not going to be doing it with your eye. If you have this kind of eyes, there is no reason for a pathologist, right? So you need to send actually this tissue to the pathology lab that is going to sample the margin of resection. They are going to look at the margin of resection under microscopic examination, and they will tell you if your margin of resections are free of tumor. Okay? Does that sit well with you guys? Okay, this is just, we're going to be hearing this so many times, you're going to be sick of it, but you're going to learn it, I assure you of that. All right, so right here, actually, you have two cardinal features of malignancy right there on this mass. The first one is that, the mass is invasive. Okay, how do I know that? Because it's already in the fat and it has an irregular border. The extrapolation of this is that it has invaded the nearby tissue. This is the first golden, rule or golden base of actually a malignant mass. The second one is right here. The fact that this mass gave rise to a metastasis, in this case, a lymph node metastasis, meaning the mass, the cells of the tumor have left actually the tumor mass itself and has gone into the lymphatics, draining that breast, which is present in the axilla. By moving from the breast to the lymph node in the axilla, the end result is going to be actually creating a lymph node metastasis. This is the second golden rule of a malignant tumor. So what are the two, most important, the most, golden rule of malignant mass? You look for two things, invasion and metastasis. Remember that. All right, what else? Also, you see that the mass actually is really large, right? That's because I told you that cancer is a genetic mutation, right? The cause of cancer is a genetic mutation. The genetic mutation of malignant tumors is a very complex mutation. It's a very powerful mutation that is able to give rise to a large number of divisions, okay? And by doing this, it can actually acquire very large sizes. Now, you see also that the nipple has been retracted. And the reason for this, it's a little bit more advanced, but we can talk about it now. That the tumor cells enter the lymphatics beneath the nipple, okay, and creating an inflammatory condition, then it heals. When it heals by fibrosis, actually retracting the nipple inward. And that's another sign, actually, that what you are dealing with is a malignant tumor. All right. So this is, a section of a normal breast. What do you see in the breast? If you think about it in terms of histology, you see three components, right? Fat, glands, the epithelial component, and stroma. Very good. All right. So if you look at the normal breast tissue, you will see that the fat is clear of any kind of epithelial component here. Do you agree with that? It's what we call open fat. Nothing, wrong with it. Then if you look at the lobules are actually contained within its own boundary, correct? So this is one lobule that is in its own boundary. Here's another lobule that it's in its own boundary, the same right here, here, and here as well. The stroma is open, correct? Is there any epithelial component in the stroma? No. The stroma is clear of any epithelial component. Now, one of the important features, one of the cardinal features of malignant tissue on microscopic examination is the feature of invasion or infiltration. So how does that happen? When the epithelial components, the glands of this lobule leave this place and invade the stroma on their way somewhere else, that's actually called infiltration or invasion, okay? So in this case, you look at this section right here, which is a section of a breast cancer, and you will see that all the stroma is busy. Do you agree with that? Yeah. Okay, so infiltration of or invasion is a very important feature. This is one. That's what we call architectural feature. For a cancer, you have architectural features and you have cytologic features. Of course, you don't need to worry about the cytologic features, at least not in this lecture. You will be getting more and more as we go through this series. So this is one. Two, you look, what is this right here? Fat tissue, right? Is the fat clear of epithelial component here? No, these fatty cells have invasive epithelial components coming to them. So there is invasion of the fat, another cardinal feature of malignant tumors in the breast. Okay. And then you look at actually this duct right here. Now this duct right here should not have this kind of lining. Why? Because this lining is very dysplastic. We'll talk about what dysplasia means in the next few slides. But let me break the ice from now and tell you that this does not look like a normal lining of a breast duct, because the cells look very abnormal. If you look at these cells, you will see that these cells have very large nuclei, very large dysplastic nuclei, and there are a lot of mitoses. You see these cells with holes? There are a lot of mitoses, far more than what you expect in normal cell. So this is ground zero for the formation of the tumor. This is where the tumor formed in the first place. What we call a breast cancer in situ, or cancer in situ. And the components that you see surrounding them, all these glands that are invading, the stroma came out of this, ground zero right here. Now that your question will be, how come, that we don't see it coming out of this duct right here? How would you answer that?
You don't see it from the duct.
Right. So what I'm telling you that all of these malignant cells and glands came from this malignant duct, from the cancer in situ, where everything started. So what happened actually at one point in time, this malignant duct started, the tumor cells in it started to breach, to go through the basement membrane, okay? To break through the basement membrane and become invasive cancer. Are you guys with me, or did I lose you? That's pretty simple, right? Like we're gonna get to actually the actual, description and piece by piece, but we can start it from now. Right, but then at one point in time, the tumor cells will invade, right? So this cancer, you're absolutely right. So this cancer in situ will turn from a cancer in situ into invasive carcinoma, right? So I'm telling you, you have to take my word for it. There's a lot of trust between us. I'm telling you that all these cells and glands that are malignant, that are invading, came from here. So how did this happen? How come that you don't see it? The reason for this is a duct, right? So the invasion may have happened at a layer or at a level that you don't see in this section. Okay? Are you guys getting the 3D, understanding of this?
But if we were to ever cut that section, we'd be able to see it, right?
If you what you call bread loafing. I told you pathology has a sick tendency of using actually, food terms for horrible diseases, and this is one of them. If you bread loaf it, eventually you're going to get to the point where you're going to be able to see that there is, part of this tumor that is breaching through the basement membrane of the cancer in situ and becoming invasive, giving rise to all these cells.
Is the same as the circle?
No, this is different. This is not the same patient, different patient completely. Okay. Yes. Okay. So are we somewhere on the same page?
Yes.
Okay. I will be happy to be anywhere on the same page. That would be good. All right. So diagnosis. That's malignant tumor of the breast, carcinoma of the breast. So what's a tumor? Tumor is a lump, right? But tumor itself actually means a little bit more than just a lump, because there is what you call a true tumor and there is what you call pseudo tumors. Could you give me examples of what may give rise to a pseudo tumor? Aneurysm may give rise to a pseudo tumor, absolutely, because it will present like a swelling, right? Yeah, but what else? Granulomas will be a pseudotumor, absolutely. What else? Infection, who said infection? Excellent. Any kind of chronic inflammation, right? Any kind of infection, as a result of the edema and as a result of the influx of the inflammatory cells, it will present like a mass, right? But is it really a tumor? No, because for a tumor to be actually true, it has to have dividing cells, right? It has to have that parenchyma that is going to be, dividing, or the mesenchyma in this case, if it's a mesenchymal tumor, that is dividing, giving rise to this, tumor mass, okay? So there is, a what we call a true tumor, and there is, the pseudotumor, something to keep in mind. All right, so definition of neoplasia, I think by now, I told you that, still unfortunately in the medical literature, you still see a lot of those words that don't really, match what we know about cancer now. So you see the word uncontrolled. Is a cancer cell or a cancer tissue really is uncontrolled? The answer to that is unfortunately not. It is a highly controlled process. Of course, it's an abnormally highly controlled process, but it is controlled for sure. I kept this from Robbins because you're going to be seeing it in Robbins, but you actually get the point. You are actually, I think, pragmatic enough to see that there are two, faces to the same coin. So in reality, the tumor cell is a highly organized cell, is a highly dedicated cell for one purpose and one purpose only, which is the purpose of, creating a tumor mass and then gaining access to blood or lymph and then metastasizing. All right, so a neoplasm, we did talk about this. So take that with a grain of salt. One thing I want you to remember from this slide right here is the word autonomous, because this is absolutely correct. A tumor mass is a tumor mass is an independent entity. It does not really need any kind of hormonal stimulus. It does not need any kind of growth peptide, any kind of signaling, mechanism. It does not need any of that. It does have all of that itself. How does it do it? Through the genetic mutation that it harbors. All right. Now, tumors in general could be divided between benign and malignant. Now, if you are a little bit more interested, we know now that there is a third actually category, which is called borderline. So there is benign, borderline, and malignant. Borderline tumors usually are tumors that, for more or less, they do not really invade, but, you take them out, they recur. Unfortunately, those tumors, you cannot trust the tumor. So a borderline tumor, even though the majority of them do not invade, they may at one point in time go into a higher grade and become invasive and kill the patient. All right, so we have learned, tumor. We have learned, the definitions of benign versus malignant. Now, when it comes to benign tumors, benign tumors are also monoclonal, population, monoclonal proliferation. Any tumor, when you say the word tumor, you're referring to monoclonality. Okay, so monoclonality. What does monoclonality means to you?
That they're all made from the same, only one.
Very good. So all of them came from the same source, from the same cell, right? From the same gland, from the same follicle. Now, how would you describe clonality in terms of actually how could you establish clonality or monoclonality?
A large number of cells.
Large number of cells that what?
That's also the same DNA, proteins,
Right.
everything.
Excellent. So all the a large group of cells that came from a single cell, right? From the same cell. Now, this same cell, as a result of the fact that it gave rise to so many cells as a result of the cell division that it underwent, or as a result of the same genetic mutation that resulted in lack of apoptosis, or as a result of cell, maturation arrest that resulted in a leukemia, for example, diagnosis, all of those cells will look like each other. So that's one way to establish monoclonality is by appearance. All of them will have the same appearance. All of them will carry the same genetic mutation. So if you do actually any one of those cells, you send it to the cytogenetic lab, for example, you will see that all the cells will carry the same translocation. Okay, if you do immunohistochemistry studies, you will see that all the cells will carry the same proteins on their surface. All right. If you do EM studies, electron microscopy studies, you will see that all the cells will have the same, type of vesicles, for example, in their cytoplasm. All of those examples that I told you now are examples of monoclonality, okay? Because you're establishing that all of them carry it and all of them are the same. Metastasis, I have just given you an example of metastasis. Now, before that, we're going to be talking about benign versus malignant in the next lecture. I don't know when that's going to happen now or next week, inshallah. So the difference between benign and malignant tumors, the genetic mutation that is present in malignant tumors is a far more complex genetic mutation than the one that is present in benign tumors, and a far more powerful one. So as a result of that, it will give the tumor cells the ability to divide higher number of times and to give rise to more number of cells. So as a result of that, the tumor mass in malignant tumors will be much bigger than the tumor mass in a benign tumor. Okay, this is one way to differentiate. The size of the tumor is going to be one of the ways to differentiate, especially, for example, this is something that you're going to be seeing in year 3 in endocrine tumors. Endocrine tumors, the cell cytology are not really that very important. So how would you be able to differentiate benign from malignant? Believe it or not, one way to do that is going to be through the weight of the tumor. The size and the dimensions of the tumor is going to be one of the ways to distinguish between benign and malignant endocrine tumors. Another feature actually is that benign tumors, for the most part, are going to be surrounded by a capsule. As I mentioned to you, either a true capsule or a pseudo capsule. That is going to be, simply, encompassing the whole mass of the tumor. Now, malignant tumors, on the other hand, very rarely are going to be actually surrounded by a capsule, very unlikely to be surrounded by a capsule, okay? And if there is a capsule, in a tumor mass, that was benign at one point and now is breached by the tumor cells, then the definition of this tumor is going to move from benign to malignant. Where do we see that? We see that, for example, in thyroid tumors, because follicular adenomas / follicular carcinomas are very close entity. And the difference between the two is really the capsule of the adenoma. Once the capsule of the adenoma is breached by the tumor cells, then actually that definition is going to move from benign to a malignant follicular neoplasm, in this case follicular carcinoma. Metastasis, we did talk about this. We talked about actually the lymph node metastasis that happened in this patient, but there are other ways of metastasis. For example, do you guys know any other ways of metastasis? In the blood, which is going to be worse, the lymph or the blood?
The blood.
Right. But eventually the lymph is going to actually end up in the blood again, right? The thoracic duct eventually will drain in the blood, correct? So why is it so, better prognosis, in the blood than in the lymph? Do you guys know? The reason for this is that the lymph route is going to delay the spread of the tumor. It's going to put it off. It will give the patient a couple of probably years or a certain period of time before it goes into the blood and starts it's going with the flow. Now, is there any other form of metastasis you know? Say it again. It's better than that, right? Because it will it will retard actually the spread of the tumor some. It will delay it. Okay, so what else do you know?
For example, from gallbladder to liver.
Right, that's direct extension, absolutely. Going through, but that's what you call invasion, actually, not a metastasis. Okay, so how would you? What else? What other form of metastasis do you know about? CSF, excellent. So the CSF spread. So what happens? Some of the tumors that grow in the CSF eventually will exfoliate. The tumor cells will exfoliate and start to bathe themselves in the CSF. And then, the CSF will take them everywhere in the CNS. That's what you call actually a direct spread of tumor cells. That's another way of metastasis. Where else do you see this type of metastasis? The direct spread. Any cavity, where is that? Not heart. But usually, the heart, you're right. The heart would actually be the fact that there is a pericardial cavity, right? pericardium, but that's very, very rare. Why? Because, there are very, very, very rare, malignant tumors of the heart. Peritoneal cavity, absolutely. What else? Peritoneal cavity for sure, and also pleural cavity could do the same as well. So they will break from one area, and then, the fact that there is a pleural fluid and peritoneal fluid, they will start to go everywhere within that cavity, and then the tumor cells will start to establish actually a tumor on the surface of the tissue of that cavity. One very famous tumor that we will see in the next few lectures is called the Krockenberg tumor, a tumor that arises, the primary site of the tumor is somewhere in the GI, either the stomach or the colon, and then eventually the cells, after they go, through the lumen of the organ, they are going to invade through the walls, reach the serosa, and then, from the serosa, they will break apart, and they will reach actually that cavity, base themselves in the peritoneal cavity, and then end up on the ovaries. And when when it will grow on the ovary, it will create a satellite in the ovary known as a Krockenberg tumor. So it's an adenocarcinoma that has its origin in the GI tract. All right, we did talk about actually, where the original tumor cells. If the original tumor cells is an epithelial cell, then actually this is what you call a carcinoma. The malignant tumor that will arise from it is a carcinoma. When it is actually a mesenchyme cell, it's going to be a sarcoma. Now, carcinoma and sarcoma are two very different entities. You will see that, the features, the, morphologic features that we will learn about, a cancer cell or a malignant cell is going to apply to both of them. But in terms of their mechanism of development, in terms of their behavior, clinical behavior, they are different entities. Grading is something that, the pathologists will do to a tumor. So, when the pathologists receive, the cancer tissue, one of their missions is to actually grade the tumor mass that he is looking at under the microscope. And the grading will happen in this form. You are going to be calling the tumor either a well-differentiated tumor, a poorly differentiated tumor, or a moderately differentiated tumor. So how is that? Why are you doing this actually? You're doing this because the assumption is that the histomorphology, the grading histomorphology that you are doing is going to mirror the clinical behavior of the tumor. So when you are telling the treating clinician that this is actually a well-differentiated tumor, you're telling him actually that I expect, and you have to expect, that this tumor is going to behave in a good way. When you're telling him that this is a poorly differentiated tumor, you're telling him that this is going to be a horrible tumor for the patient, and the patient is going to actually suffer from it tremendously. Moderately differentiated is somewhere in between. It's a very rudimentary kind of help, if you ask me. Now, one of the things that was accumulating over the years, it was shown that this rule is not always true. That a well-differentiated tumor might not actually behave well all the time, and that a poorly differentiated tumor or a moderately differentiated tumor, on the other hand, might not be so bad. So as a result of that, this is when actually molecular medicine came to the rescue. Molecular medicine and other tools in science, including bioinformatics, came to the rescue and started to look at other features that are going to help you, the clinicians, in actually grading clinically the tumor at hand. So it started to, we started to do things like, for example, the genome-wide assays. What is that, guys? Have you ever heard this name before? Anybody has done any wet lab research? Wet lab research. Wet lab, meaning you're doing it with your hand, not medical education, or survey. That does not count as research, at least to me. You have done wet lab. Okay, so genome-wide analysis, you should have an idea at it probably. Genome-wide analysis, the PCR test, when it came out, PCR looks at one gene at a time, okay? Genome-wide analysis is going to look at the whole genome of that cell at the same time. So it will tell you, which gene is overexpressed, which gene is underexpressed, which gene stayed the same way compared to normal. You have to have a control, which is a normal tissue of the same kind. So when we started to look at the other actually indications, molecular medicine was able to deliver a lot more information than just simply the grading of the tumor. So now it will be a well-differentiated tumor expressing this gene. And that gene expression is far more important than what the histomorphology diagnosis is, because that gene expression, after a lot of, again, clinical data that has been accumulating, after what you call, evidence-based science has accumulated on that gene, it will tell you, for example, by the studies that has been done, if this gene means that the patient is going to do better or worse. So by adding this piece of info to the medical report of the patient, you're getting really a lot, you're giving the patient and yourself, the treating clinician, a lot more space and a lot more information about how to predict the behavior of the tumor. Now, stage of the cancer, this is what you do as the clinician. So grading is done by the pathologist. The staging is going to be done by you. Staging is, part of the staging is the pathologic diagnosis. So how do you do staging? Staging is done when you do an X-ray of the chest to see if there are any mets to the chest. When you do, for example, a CT, a CAT scan, of the body to see if there are any distant mets of the tumor. When you do bone marrow biopsy, to see if the tumor is in the bone marrow or not. All of those are actually, staging of the tumor. Why do you do staging? You do staging because that is going to, again, to give you the correct prognosis and correct, at least it will give you a very good idea, hopefully, about the clinical course of the patient. And also it's going to help you in choosing the right, treatment for it. Again, this is coming, we are here, but there is a long list of a clinical data that has accumulated that told us, for example, that stage 2B is amenable, is responding to this kind of treatment. So you do staging because you will be able to pick the right management, for the patient. The best stage, what is the best stage that a tumor could be at in terms of quote unquote cure for a solid tumor? Not inside, this is in situ pathology, right? Which is the equivalent going to be of stage 1A. The Roman 1A. So that's going to be the smallest tumor possible that has not, presumptively has not gained access to blood or lymph. So it is still localized. And the only treatment for that hopefully is going to be a curative treatment, is going to be actually going in and taking it out with surgery. Okay. So surgery, stage 1A, remember that. All right. Oncology is the science of that studies all of that. All right. Now we go back to the fun. Amazing. I did not hear my voice in a long time in a lecture, so I just did it with you. It feels good. All right. I'm happy that you guys can still hear me behind, the levels of mask that I have. We can't be so sure, right? In our day and time, anything can happen with this crazy thing that is ongoing, unfortunately. All right, we did actually study, when it comes to the cellular adaptation, if you guys recall that from, distant memory, before the midterm. We studied the hypertrophy, hyperplasia, and metaplasia. And we said actually that this is, this was going to be a, what we call a very, again, like, I cannot even talk anymore because the muscle of my mouth are very tight. So I have to take that out. I apologize. Excuse me. All right. All right. So we said actually that the hypertrophy, hyperplasia, and metaplasia are what you call temporary solutions, right? Temporary solutions to the transient, stress that the cell is going through. But if you recall, also we said that if hyperplasia and metaplasia starts to become chronic based, chronically present, that they may open the door actually for something that is more sinister to set in. And that sinister thing is actually going to be dysplasia. You guys recall that, right? And then we talked about, if you recall, in the first page of that lecture, the dysplasia, there is an interrupted line that actually connects to dysplasia. And I told you that interrupted line because some people, academicians consider dysplasia to be actually an adaptive process. But, the real deal pathologist, what you call it, the pathologist in the trenches, will say actually that this is not true and that, dysplasia is cancer. All right, so there's discrepancy, there's some controversy, surrounding the word dysplasia. Now, in this lecture, and you guys are pragmatic enough, I know that you are very pragmatic enough to actually to know the two sides of the coin. But to make sure that there is no confusion, there will be no question about dysplasia on the exam, because I don't want to have two different answers from all of you, and then I will be receiving a lot of negative feedback, in terms of please take that question out. All right, so but you know it well, right? So for this lecture, dysplasia is actually cancer. Okay, is that clear enough? Remember that. And to show you actually that there is always room for discussion and for what do you call it, like a different opinion, even in pathology. Pathologists pride themselves on calling pathology the gold standard, because this is the last thing that you're going to receive from the patient. It is really the tissue diagnosis that will make it or break it. It's still even true today, even with the advent of molecular genetics, because at the end of the day, you're the only specialty that use the tissue from the patient, the specialty of pathology. But even in pathology, dysplasia, the controversy is like this. Some people believe that actually dysplasia is a reversible, because it is an adaptive mechanism, that it is a reversible entity. And the example they give you, which is also true, is something like the malignant tumor that happens as a result of the H. pylori infection. You guys know about H. pylori, right? If H. pylori infection becomes chronic, it may give rise to a special form of lymphoma in the wall of the stomach, known as mucosal associated lymphoid tissue lymphoma, what is known as maltoma. Have you guys heard about it before?
Yes.
In hematology, right? No, or where? Histology, good. Good. Histology should not have taught you this. This is good to know. All right, but hello. So let's talk about actually this maltoma. So this is a very weak tumor. Okay, here's something that should really make you actually open your eyes and bring you back from your slumber that you're going into. It is a Thursday afternoon and people are relaxed, at least in the back benches. Something to, how about this? You can reverse actually. You can reverse maltoma. You can reverse a maltoma in the early stages of the disease by using, believe it or not, the quadruple antibiotic therapy that you use for the H. pylori, as crazy as this may sound. So you can treat a cancer with antibiotic and reverse it. Not in all cases and not in all stages, but in the very early stages and in some cases. But it is a documented event, if you will, in oncology, that you can reverse a maltoma. You can reverse this actually marginal B-zone lymphoma, which is the same as the maltoma. And you can actually do this with antibiotic therapy. And those people who say actually that dysplasia is reversible will point out to this example correctly and say, look, it is actually reversible. All right, but an example or an exception does not negate the rule. Have you guys heard this term before? An exception to the rule does not make the rule obsolete. It's simply an exception, and the rest of the rule will apply. Okay, so this is why in this lecture, dysplasia is cancer. All right, differentiation, we did talk about this. Now, anaplasia is something else that you need to know about. Anaplasia is a term that describes, so you have, for example, you have pretty, beautiful and beauty most, right? This is like the two, at least to me, this is the definition of beauty, right? So, and you have you have ugly, ugly, and ugliest, or uglier and ugliest. Now, anaplasia is the ugliest thing that anybody could have, really. It is, so, if you compare an anaplastic cell to a dysplastic cell, it will be far, worse looking and, worse in terms of clinical behavior than a dysplastic cell, than a cancer cell. So this is again, how can I, coming from Syria, I have to actually always resort to my, skills in politics. We are very skillful people in politics. So this is a joke, actually. What I can tell you is, for example, there is like a right-sided government, right wing governments and left-wing government. And then there is the ultra-right and the ultra-left, right? Let's put it this way. Anaplasia is the ultra-right. This is the most extreme that you can look for. All right, so how does a tumor cell looks like? So a tumor cell, looks like, if you want to describe it morphologically, it's going to actually, once the genetic mutation sets up, that tumor cell is no longer, is no longer following the normal rules of that tissue, okay? So as a result of that, it will start to take different sizes and shapes than the original cell where it came from. As a result of that, there is a term that is used for this known as a pleomorphism. Now, you are pragmatic enough to actually be able to understand that tumor cells will be pleomorphic but monoclonal. How about that? Do you see what I'm saying? Like, sometimes medicine, like beats its own self. How could I tell you that a tumor, one of the way to establish monoclonality in a tumor mass is to simply look at the morphology of those tumor cells. And if all of them look the same, then you would call this monoclonal, right? But I'm coming back again here and telling you that, hey, it's pleomorphic. I can do this because I'm giving you the material, and you are pragmatic enough to understand it and, not question it. How about that? This is what happened in medicine, is that it established, actually, it boxes you in, really. There is no ingenuity in medicine, unfortunately, because I expect you to ask this question. So I anticipated this and gave it and handed it to you right now, Hyperchromatism. Hyperchromatism, remember this actually, especially for the tumors that are going into a hyperdrive of division, that are dividing a lot. Those tumors, the nucleus of the chromatin of those tumors cells are actually preparing for division. If you recall from the cell cycle that you have taken probably in high school, is that when that happens, there's going to be condensation of the chromatin. Do you guys remember that still?
Yeah.
So this is why actually you will see that the chromatin is going to be very dense, very condensed, very thickened, if you will, and that's going to give it, the very dark staining. Now, if you also, let me remind you of that, when you actually stain a tissue, you use hematoxylin eosin. What does hematoxylin stain? The nucleus. And what color is that? Blue dark, right? Okay. So blue dark. And what does eosin stain? The cytoplasm. And that's the pinkish, right? The pinkish reddish, color that is there. Now, loss of normal orientation is another feature of a malignant cell. So you will see that the tumor cell, in a normal tissue, you will see that the head is head and the tail is tail, right? The cell is actually sitting in its normal position, in the position that it should be, taking, so that it will establish what you call a closed knit sheet of cells. So let's talk about, for example, the bronchial epithelium. One of the functions of the bronchial epithelium is to prevent the effects of what's coming into the airway from reaching the deeper layers of the bronchial wall. All right. So as long as the bronchial epithelium is intact, there is no problem. Okay. Once the bronchial epithelium starts to become carcinogenic, once it starts to become transformed, this is the word that is used to refer to a change from benign to malignant. Once the bronchial epithelium transforms, then the result of that is going to be weakening of the connections, of the cells to nearby cells. So the paracellular, connections are going to weaken. And as a result of that, what do you expect that to do, when it comes to the, to the leakiness of that membrane? The leakiness is going to increase, right? Are you guys with me, or did I lose you somewhere? I lost you already. All right, look at this. So this is normal, right? They say a picture is worth 1,000 words. Let's see. So this is normal, right? So a normal, you will see a very tight knit paracellular space, okay? Here the cell is fine. Whatever comes in until a certain point, the cell will be able to prevent whatever in the lumen from going to the deeper level layers of the bronchial wall, Okay, one of the mission of the bronchial epithelium. Now, imagine what would happen if if the connections between these two cells starts to weaken. What happened to the paracellular, space? The paracellular space will become, more actually open in that case. It will no longer be very close-knit. And as a result of that, the paracellular permeability is going to increase, okay? And the result of that is going to be the exposure of the deeper levels of the bronchial wall to whatever toxins or carcinogens are coming in with the smoking or with, occupational exposure or with whatever. Are you guys, with me? Did you get it well? Okay. So once those actually cell contacts or cell connections, also known as adhesion proteins. Have you guys heard about adhesion proteins? And also tight junction proteins. Have you also heard about this? Those are two proteins that are going to keep the cell, very, very much, closed, like a seal. This is what they call the paracellular seal, sealed next to each other. Once they start to weaken, as a result of the fact that the cancer cell will no longer be making these proteins, those cells are going to start to take different positions actually within the tissue. So they will, instead of them actually being, what head is head and what tail is tail, they will start to go oblique, they will start to go transverse, or all the way upside down, as you can see here. You can see that there is oblique cells, there are actually transverse cells, and you have to trust me that this is an upside down cell right here. So when that happens, those cells are going to be in a lot of disarray. Paracellular permeability is going to increase. And very importantly also, the lack of cellular adhesions, proteins is going to allow these cells a free movement. So when there is going to be breaching, when this tumor cell goes through the basement membrane, the cells are free to move. There are no connections to nearby cells, with these adhesion proteins. Are you guys with me still?
Yes.
Did I lose you anywhere along the way? Did I drop you somewhere? Good. All right. Increased mitosis. If you actually look at again the same tissue, see on a picture, it's much better. Where is usually the mitosis happening in normal tissue? The basal cell layer, right? The most basal cell layer, that is the cell entrusted. Let's say there is any kind of injury or damage to the upper layer. Those cell layers are going to crank up the cell division to give rise to more cells that are going to take up the place of the normal, of the cells that were lost, right? So it is limited to the basal cell layer. In a cancer tissue, this is, by the way, is a section of the same tissue. And there was a beautiful line right here. You will see it in the other older versions of the lecture. Unfortunately, I deleted it, by hitting the wrong button somewhere. There was a line that goes right here. And that's actually what you can see. This abrupt transition from normal to malignant is amazing, really. You don't really see that a lot. So that's really make one, beautiful picture for your exam, if I'm giving you some hints. I usually say the word, exam during the lecture to bring you back actually to the lecture, because I know you would have been you're on your way down, and then, you hear this, and that's going to jolt you back into action. All right, so you can see actually here that the mitosis, where is the mitosis, you may ask? The mitosis are all these cells that have this, halo surrounding them. You see that, right? All of this, are mitotic cells. Where are the mitoses? The mitoses are all the way up towards the surface of the cell. So it's no longer actually limited to the basal cell layer. Okay. Say it again. Yeah, the clear one, right. Where is that? The clear one right here. All of those are actually mitotic cells. Not only this, but if you look at this mitosis, you will see that actually the shape of the mitotic spindle is very abnormal. This is what pathologists, they have very, nice words to use for that. They call it weird mitosis, At least this is histopathology. Thank God for molecular medicine. It came back to bring back, pathology from, the non-scientific words they used to use. But again, actually, it is a subjective, pathology used to be a subjective science. And if the pathology head is powerful enough, he can say any word, and you only have one way to answer to that, which is yes, sir. There's no other way around it. Of course, now it's no longer the case. Why? Because instead of actually relying on these unscientific words like a weird mitosis and ugly cell, you have actually a readout that comes out of a machine that is actually courtesy of molecular medicine and bioinformatics. This actually is becoming a reality. It's no longer a research actually based practice. It's becoming what, in the West, it is being used on a daily basis for diagnosis. All right, so let's talk about actually the features of malignant tissue right here. So one of the features of malignant tissue, of benign tissue, is maturation toward the surface. So if you look at the basal cell layer, you will see that there is actually cells that have a larger nucleus, right? So the NC ratio in this case will be what? Will be large because the nucleus is large. As you go through the upper cell layers towards the surface, you will see that the blue will be gone and there is going to be more white, right? And more lighter actually color. That lighter color is the cytoplasm because the nucleus will become smaller and smaller, and then it will become pycnotic way all the way up on the surface of this tissue. So what do you expect the NC ratio in this case to be? It's going to be very, very small, right? So this is actually what you call the feature of maturation towards the surface. Then the normal orientation, all these cells, lay in a normal position. What is head is head, and what is tail is tail. Number two. Number three, mitosis is limited to the basal cell layer. We just talked about this. And number, four, remember this word from now, the cell's nuclei look very bland, B-L-A-N-D. This is an American word, they love to use it for some reason. They say this is very bland. Very bland meaning very unimpressive. It does not really catch the eye, if you will. And as opposed to what you're going to be seeing here, everything is impressive when you look at the malignant tissue, unfortunately. So the malignant tissue starts from here, from this what you call cookie cutter border. And if you look at these cells, you will see first that there is no maturation toward the surface. Do you agree with that? Because the cells right there at the top, have probably larger nuclei than the cells at the basal cell layer. So there is no maturation toward the surface. What do you expect the NC ratio of those cells to be?
High.
Very high, right? So NC ratio is still very high and even higher than the basal cell layer. How about mitosis? Mitosis is very, very, busy, very active, and it is all the way up in this tissue. Do you agree with that? Yeah. And also it's quote unquote weird mitosis. Weird mitosis. Just one second, let me finish this thought first. So weird mitosis. And then eventually, you have to take my word for it. There are a lot of cells that are lying in all different directions. What you call loss of normal cell position. And we have talked, why is that the case? Because the cell is no longer making those adherence, proteins and those, tight junction proteins, and the end result is going to be, leaky paracellular, space and, increased paracellular permeability. So all of those are features actually, these are what you call the architectural features. Now, if you go on higher power, as we will see in the next few slides, you're going to be seeing that the cells itself, the cytology of the cells are also abnormal because the nuclei are going to be larger, the nuclei are going to be irregular, and the NC ratio is going to be very high. Go ahead.
So you said the inhibition of mitosis is the halo around the cell, right? So what does it create to drive them?
This is actually, well, like when the cell goes through a division, if you recall that from cell cycle, it does actually become larger than, itself, right? I believe this is also, partly due to preparation. So it's an artifact, that is added on top of the fact that the cell is no longer this, single cell, but rather it's trying to make two actually cells. The staining itself, the fixation and the staining may give rise to this whole.
Also, I don't know, just the picture itself, but the spastic epithelium looks much darker as well.
Much what? I'm sorry. Right. Which one with the mitotic cells?
Yeah, this one looks much darker.
Honestly, I think all of them look the same. It's a very dark, chromatin. The chromatin is, during the condensation when those what do you call it, fibers are going to be pulled to, both ends of the, budding cell, are going, that's also associated with the condensation of the chromatin. So honestly, I don't think that the color is very different than the rest. Yeah, probably the contrast of the white and it's because in this one, there is more contrast than in the rest of them. The rest of them, you see only the dark, here you see dark and white that actually gives it rise to this feature. All right, any other question? All right, let's see. All right, so now one thing actually that is left out here to discuss is going to be the fact that actually this is a change in the full epithelium, okay? The change has affected the full epithelium. It is not limited, to only the lower layers, but rather it's a full thickness transformation of the epithelium, which is the equivalent of carcinoma in situ, okay? So what's a carcinoma in situ? As long as this transformation is still limited by, or is still bound by the basement membrane, then you call that actually, you call that carcinoma in situ. Once it breaches, once it goes through the basement membrane, that's what you're going to be calling actually invasive carcinoma. That's when it becomes, you don't call it invasive carcinoma anymore, you call it carcinoma. Are you guys okay? You sure? You want to take a couple of minutes break, or is that not time? You want to take a break, right? Okay, all right, we can take a break. Sorry? Maybe 5 minutes break, 10 minutes break, no, not more than that. Yes. All of them, yes. They are all coming from the same cell. So they would have the same, mutation, same protein, same histology. Benign tumors are all coming from the same cell. Malignant tumors are all coming from the same cell. Right. So what I want to tell you is that honestly, there is no rule when it comes to cancer, okay? Because the presumptive thinking is that because it's a monoclonal population, all the cells will look the same, right? But that's not always the case, because once the cell has this genetic mutation, the cell itself will behave differently than the next door cell, and maintain actually a morphology that is different than your cells. There is no normal control anymore that tell the cells, this is the size that you need to reach. This is the type of vesicles that you need to have in the cytoplasm. This is, how the nucleus should be looking like or should be positioned. This is all lost. So as a result of that, you will have different. So now that will make, of course, hard for the pathologist to establish the monoclonal. But we have other tools that to do that. When you say differentiate the tumor, that means that the morphology of the cell, the morphology of the tissue looks like the most differentiated tissue, of the original cell. So let's say that you're dealing with a well-differentiated squamous cell cancer. Okay, you have to look. So the original tumor cell is the squamous cell. Where is the best well-differentiated squamous tissue in the body? So you compare your tissue to the skin. And I will come to it in the next few slides. So if the tumor looks exactly like the skin, meaning it has skeleton curls, it has desmosomes, it has actually intercellular ridges, these features are going to tell you that actually what you're dealing with is a well differentiated film.
Even though this is not in the story,
Exactly, exactly.
compared to
Exactly. To the original cell. So let's say that you're saying, actually, this is a adenocarcinoma let's say adenocarcinoma of the lung. Okay, which you should not. No, you shouldn't expect it. What else not should expect? Squamous cell carcinoma. Okay, of the lung. Okay, it should not really arise in the lung. Okay. Again, you compare it to the skin. Okay? If it looks like the skin, 100% that's well differentiated. If it does not look like anywhere near the skin, it's a fully differentiated. If it has features of both, that's going to be called well differentiated. Right, well, there are features of the squamous, psychological features. So first, the squamous cell usually is going to be what's called 2D dimensional. The sheet of the squamous cell are 2D, two-dimensional, as opposed to the adenoid features, the adenoid structures, which is a ball. So it's a 3D. Okay. So one thing so you look at the cytoplasm of the cell itself. The cytoplasm of the cell is going to actually look very gassy when it's a twin cell, as opposed to what you see in the whiskey cytoplasm of the adenoid structures. You see what I'm saying? So there are psychological features that can tell you you're dealing architectural and psychological features that what you're dealing with is actually a right. Because when you say fully differentiated tumor, okay, well, the way to think about it is it's a fully differentiated tumor because it did not grow to resemble the most well differentiated, tissue of the original. That it is actually, it grows in such a chaotic way that it created a tumor that is so, different than the original, which means the presumptive thinking is that this tumor is going to behave very badly. Okay? And then if you compare, like, does the skin behave badly? No. So if it's a well differentiated tumor because it looks like the skin, then it has to behave in a good way, if you think about it. Okay? Right. So there's actually invasion of the lymphatics that are lying beneath the liver. And that's going to be really the cause of everything that will happen that will result in the lymphatic of those lymphocytes. Okay. It's more than just inflammation, but inflammation is part. So it will result in inflammatory reaction. But it's not the only thing that will happen. There's more to it than that, including some contraction of of some muscles actually that are going to hold this lymphoid, right? All right. It was just an example to add to the malignant features that are seen in breast cancer. Right. Well, mechanism of killing cancer. Let's look at mechanisms. For example, let's talk about, for example, a carcinoma of the lung. One way for it to kill, actually, if it goes and result in complete closure of one of the bronchi, right? Our stop. That's a bronchogenic carcinoma blocking the lung, the lung bronchi, and as a result of that, there's going to be anti-ectasis. Very likely, this patient who develop this kind of cancer is a smoker. You already have COPD. So his respiratory system is already compromised. And the ectasis to it, that will put in a respiratory failure and death. Okay? Right. So it may limit the function, it may actually result, let's say that actually another crazy way for it. You can do anything. One another crazy way for it to happen If it grows in the context that it's growing in, it perforates. The cancer perforates and not the escaping of the blood. That will result in actually tension pneumothorax that may kill the patient. It may result in actually a breach of a blood vessel, okay, resulting in bleeding, okay, and as a result of that, the patient will be because there is no recovery. It may result in if it's in the upper like part of the lung, it may actually surround the trachea. A compression of the trachea resulting in asphyxiation. It may result in actually in there's a it may actually go after the phrase nerve. You know, it will invade the phrase nerve, destroy the phrase nerve. What happened to the most important movement for the respiration is the diaphragm movement, right? So the diaphragm will not be functioning anymore. So that's going to be called positional asphyxia. Similar to what if you put someone on the floor and sleep on his chest, he will not be able to breathe anymore. They call that positional asphyxia. Do you know who died as a result of positional asphyxia? Do you guys know who died as a result of positional asphyxia?
It's not by America, what's his name?
Isn't that guy who?
Huh?
Yeah.
Joshua? No. Your friend is going on to something. She heard it, I'm sure this is why she went directly for it. That means you're a strong fan, you're a Caesars fan.
We can do.
Not interested. Not expressed it. Not expressed it. He died as a result of, so many different people, right? All right, are we back? Did you get the name? Was it who you were thinking or someone else? Right. He was ODing. He was overdosing on some crack, in the bathroom. So this is why, and then, he fell from the bathroom, and he was stuck between the bathroom and the wall. And as a result of that, he could not breathe. So this is what's called positional asphyxia. All right. Huh? In the bathroom, right? On from the stool, he was sitting on the stool. He actually, because he was very disoriented from all the cracks he did, so but at least he died happy. This I did not say that. I hope you're not recording this. Are you? Right. So, like at least, this is what I was just discussing to your friend, Ouban. Yeah. So what I wanted to tell you is that actually that you would think that all the tumor cells should be the same because they are monoclonal, right? But that does not really hold true for the malignant tumors. The reason for this is that the normal control is lost. So the cell could not tell itself, and the nearby cells could not tell themselves that this is the size that I need to be at. This is what I need to have in my cytoplasm. This is how my nucleus should look like or should be located within the cell. This is all gone now. So it will be all sizes and shapes, really. Okay. Say again? The benign? No, the benign should be the benign. Because the benign is actually, by definition, it is a differentiated tumor. So it will look very monotone. Okay? All tumor anytime you have what we call a polyclonal mass, that's either inflammatory or hematomatous or something else. Sorry, it's not a tumor, no. This is what we established. Let's say that you have actually a tumor mass in the blood. You do one technique known as actually flow cytometry. Okay? You're looking at specific, CD markers that are present on the surface of those cells. All of those cells should carry the same exact markers. So let's say they are going to be CD20, CD19. All the cells will carry CD19, CD20 to make them, for example, a specific subtype of, B-cell lymphoma or B-cell leukemia.
If I look the mouse through the microscope, I would search the different types of cells. It's not a house. If I look at math under a microscope, I don't have like 25 cells.
Right.
I know what it's not a house.
No, it cannot, because we just actually thought that the malignant tumor may not look, that the cells may not look all the same. Because the cells are no longer bound by a normal host of that tissue.
But they still have the region. Like when you say, like what you say, all the same cells, they're all divided the same.
Right, if they are well differentiated tumor cells, they will look like, the skin, cell that we talked about. But let's say that it's a poorly differentiated tumor. For you to establish normality in this, you can have the cells take all different sides of the chain. No, by looking you will not, but then you will do, for example, you will do certain analysis. And you will see that all the tumors carry the same translocation. You will do immunohistochemistry, and you will see all the tumors carry the same protein. You will do EM studies, electron microscopic studies, and you will see all the cells carrying the same message in the same location. Okay? So all of these are established actually. You do flow cytometry, and you look at all the cells carrying the same CPs. You see what I'm saying? So there are many ways to establish monoclonal. And even if you look and see that all of them are actually look the same, you need to still establish the monoclonal. So morphology is very weak kind of activity. Say again? They can still exactly. This is what that works at. So even though they may look different, they could still be the same. All right. What happened here? Why did we go through this again like yesterday?
Oh, they screened one dark.
Yeah. I don't like to, and there is no way I don't have a. Can someone help? Any technical help? You get it?
And there's a button, yeah.
Yeah.
Did it work?
Okay.
Yeah.
As you can. Give it a lot of.
Well, I figured it's like press here. No, it's not like press here. There's a button here. Yeah, it's turning. It's flickering. It's flickering. I pressed on the buttons. It's flickering. Oh, sure, the button.
So it comes and goes. This is what's going to happen.
Yeah, I think.
Let's reboot the system. Maybe this is how we do
It
it.
will take so much.
Oh, really? How would you want to do it then? I don't have any.
Official.
Does anybody have a pointer?
I guess we had one, but I'm not sure.
Oh, there. No.
Doctor, can't you like point to
This is
gonna be
very-
hard, yeah, but anyway. Yeah. Just talk to IT, but they all have to.
Okay.
It is lighting up, no, I don't know why it's not lighting. What is flicker?
It's not flicker, it's recurrent, the thing.
No.
Out of this. How we do that? But how long does it take to?
Look at IT later.
No.
Rebooting the
Oh,
system. The
rebooting.
problem is with the screen itself.
What happened? Yeah, but even like if you reboot everything, but Sorry?
The IT said he's coming?
Okay. Thank you. We can continue on this.
Be a bit hard.
There's no pointer.
Yeah, you know what? Let's do it like this until he comes. Let's see what we can do something. Okay, thank you. Thank you for coming. All right. Okay, so in this case, actually, I don't even. You cannot move that, of course, right? Yeah, it's like a. I know, but there's a cable. Yeah, so. No, that's okay. That's okay. I don't think. And can you extend this? Like it's almost like a mission impossible. All right, and you cannot. You have to do it here. All right. So this is normal right here. Okay, this is the normal. You can see the maturation that is still happening. Okay, towards the surface. Compare that to this right here, where actually you see that there is no maturation that's happening toward the surface. Cells at the surface very much look like the cells at the bottom. Okay, so that's actually this plastic tissue, meaning it's already a cancer. Actually, this is a cancer in situ. How do I know that it's a cancer in situ? Because it is still bound by the basement membrane. Now look at this part of this tissue. Again, I apologize for the technical difficulties. All right, look at this cell right here. You will see like 10 pathologists sitting next to each other, one telling the other, look at this ugly cell. This is a very ugly cell. Imagine this is science. This is how it used to be in histopathology. Thank God again for molecular medicine. We, brought back, pathology to life again. This is what we call a self-advertisement. Yeah. All right. So, this is what you call a really, really ugly cell. And you have to agree with me, right? Doesn't it look like that? Okay, so, again, why do you need the word anaplasia or anaplastic cells? This is what they will write in their histology report. They will say actually that this is cancer with a lot of anaplastic cells that has been seen. The reason for this, you're telling the treating clinician that this is very likely going to be a very aggressive tumor. Okay, because it does have this subclone that looks so bad. All right, and now why does this cell look so bad? Compare this anaplastic cell, right here. Now the mouse is not working. Let's see if I will be working in the next 10 minutes. Okay, this is like this. All right, I'm going to be writing a nice email after this lecture actually here. All right, you can see that right now.
Yeah.
This is the tip. This is where the tip is. Okay, compare that to the dysplastic cell. So the dysplastic cell itself is larger than a tumor mass, at least the nucleus, really. It's a tricky thing, really. This is something that you need to think about, for many years to come. Let's say a high-grade tumor. When people, hear the word high-grade tumor, they say, that means actually that the cells are large. In reality, the tumor cells of a high-grade tumor are smaller, believe it or not, than normal cells. So what happened in a high-grade tumor is that the nucleus becomes very large and the cytoplasm is shed away. So what happened to the NC ratio? What happened to the NC ratio? The NC ratio goes through the stratosphere, right? Because it becomes all cytoplasm. I'm happy that you are the technician that came.
الله يخليك.
بس طلع لي على هذه هنا الله يخليك. يا رجل تعمل ايه؟
لا هون نزل تبعه
شو هي؟
في زر هون الشاشة
واو.
طفيناها إن شاء الله.
عارف السمك مطر. Right? Thank you
Sorry.
so much. Thank you so much.
All
I
good.
appreciate that. Very good. Excellent.
سلم عليك.
الله يسلمك يا رب. سلم لي على مزبوط. Okay, very good. All right, so there was a button here actually, so that happened in other lectures between the panel and the computer itself. Okay, so you can see this very ugly cell, right? You agree with them actually. You have to agree with them that it does look very ugly, and actually they're not only that, but there are other cells as well. All right, so you can see also another feature that we have talked about. Like you have to give it to pathology really, because pathology is a description kind of specialty. You have to sit and hear some of the histopathologists, especially dermatopathologists, some of the people I trained with, when they actually sit and describe and offer differential diagnosis. It is really the work of art, really. You have to sit and be in awe of this, of their way of deliverance. So having, bad mouse pathologists enough, I feel that I have to give them also credit for what they do best. Of course, but molecular pathology could not be beaten. I have to always, go and, promote my own specialty. Anyways, you look at those actually, at those mitosis, and you have to ask yourself, what is going on with them? Some of them are going to be what you call a smudge mycosis. Look at this smudge mitosis right here. You see that? Smudge, so that you cannot really discern anything. There are no spindle, there are no actually, two ends of the cell that are preparing for division anymore. Some of them are a tripod, so it's not a bipod. Some of them are tripod, okay? Some of them are star-shaped. Why is that happening to the chromatin, in your opinion? Overstimulation.
It's a possibility. Maybe it's not making the proteins that are responsible for the mutation and coiling. Is the mutation happening?
It's in the nucleus, right? So when the mutation happens in the nucleus, that's going to make the chromatin very fragile. So when the cell try to actually, to divide, it's going to break into so many different pieces. Does that make sense?
Yes.
Okay. So this is why actually you have this many different, shapes of the mitosis. Go ahead.
Doctor, I don't see how the dysplastic cells are bigger than the cars.
Bigger, they are not bigger than this. They are not bigger. I mean, this one right here, the anaplastic cell. Or do you mean that dysplastic cells?
Yeah, because you said
No. This is I'm telling you about something that is unrelated to this picture. When you talk about high-grade tumor, the word high-grade, will infer to the, to the unfamiliar, person, that it means that the tumor cells are large. In reality, the tumor cells are not really large, even in high-grade tumors. What happened, the nucleus becomes large, but the cytoplasm is shed away. So the end result is going to be that there is a very small amount of cytoplasm in the cell. So the whole thing it's actually the NC ratio will be through the roof. That's all it's need to actually, you call it high grade. Okay.
so, like in general, is the dysplastic cells larger than the?
Then normal cells, in this case, probably a little bit or almost the same size. Compare this to this here. The nucleus is much larger. Do you agree with that? But the cell overall is not really that large, right? Has not really gone that large. Now that's as opposed to this one here, to this anaplastic cell. So where it is much larger, and you can see actually here's another smudge. You see that where the tip of the arrow is, another smudge, kind of, mitosis right here. Okay, really very weird, looking mitotic figures. All right, so here's another actually full transformation of the epithelium. You may open a book and you will see that, they say that it needs, for a cancer in situ, you need 2/3 the transformation. Other books will tell you that, hey, no, it will need 3/4 transformation or full thickness transformation. Of course, that's not really for you. This is one, this is for the pathologist. And a lot of them actually are tissue dependent. So depending on the tissue that you're dealing with, the definition of a cancer in situ, may be different. But at the end of the day, all of them are going to actually have the same features that you're looking at here. You will see that there is lack of maturation toward the surface. The cells are sitting in all different directions. Mitosis right there. Look at this right here, at this weird mitosis right here. There's hyperchromatism for sure. Okay, here's another weird mitosis that's happening here. We did talk about loss of normal orientation and the cell sitting in all directions. What else? And then the only thing that is left really for this to become a full-blown cancer is actually the intactness of the basement membrane. Okay. All right. Okay. All right. So tumors. So maybe well differentiated. We already have talked about this, so there's no reason to. And why do we do that? We already discussed that. Neoplasia, and why do you need to mention it in a histology report? You're telling the physician, this is an aggressive tumor and be warned about this. Here's an example, actually, morphology of a benign tumor. So a benign tumor, by definition, is the most well differentiated a tumor that there is. It is the most closely related to the, to the cell of origin. So this is a chondroma, a tumor arising in the bone that is actually of a cartilaginous, origin. And this is a normal cartilage. Compare these cells to these cells right here. The cells are very comparable. The cells, have a very bland nucleus, as you can see here. And here the same thing exactly, nothing impressive about them. A very important feature, you will see that as you go through the body, each tissue has its own, features of malignancy. One of the important features to look at in cartilaginous tissue is to count how many cells are present per lacuna. Here you have one, this is normal, so this is 1 cell per lacuna. In a benign tumor, it is also 1 cell per lacuna. If you go, let's say, for a chondrosarcoma, you're going to be seeing multiple nuclei in each, multiple cells in each lacuna. All right, so the only thing different between here and here is what, in your opinion? See the color, thank you very much. But that's not really what I'm looking at. The number of cells, right? There is more cells here than here, correct? Which is the definition of a, of what a tumor, even a benign tumor, does. Now compare this to this one here. So this is actually a tumor arising in a site, okay? And your reference tissue is the skin, because this is a squamous tissue. All right, so what does a skin do? What does a skin do in terms of actually morphology? It has keratin pearls, right? It has intercellular bridges, right? And on EM, you're going to be seeing the desmosomes and the other features of a of squamous tissue. Now, if you look at this here, this is actually making keratin, right? If you go on higher power, you have to trust me. There are intercellular bridges, and have all the features of what you call a well-differentiated skin, right? The skin tissue. So this is what you're going to be calling as the well-differentiated squamous cell cancer. Okay. If you compare the tumor cells to to the skin, and it does not look like it at all, that's what you're going to be calling poorly differentiated squamous cell carcinoma. So the question that should come to your mind is, how do you know that this is actually squamous cell, right? Then you have to trust me. Again, there is a trust issue that we should raise in this case. This is a joke. What I'm telling you, you have to take it from me that this is a squamous cell. But believe it or not, even for the experienced pathologist, this is a tumor from hell. Why? Because they have to establish that this is actually a squamous cell on an adenocarcinoma, cell tumor. And for that, there is, other studies that could be done, for you to actually to discern or to discover the nature of the tumor. One of the things that they will do, right off the bat is going to be the use of immunohistochemistry, okay? And also probably if that is going to be hard, especially for example, in endocrine tumors, they may go and do electron microscopy studies. Sometimes it may go as well, as high as electron microscopic studies. And, to look for any features, so they take so many sections, of the tumor mass to see if there are, areas within the tumor, that does actually show some squamous differentiation. Okay, so it's a pretty tough work actually when you are dealing with a poorly differentiated tumor. There are books and there are many, many articles that have been published about tumors of uncertain origin, and how to go about actually establish them, establishing their identity. Okay, and there are algorithm which is not related to you, but in case you like to hear it, you may ask me, on the side about it. There is an algorithm that you can go through that will make you reach a diagnosis, of this tumor of uncertain origin. Now, if the tumor is going to be like this, which is what you call, a tumor that is borrowing from both ends. Part of it is actually squamous, and you may see some keratin pearls here and there, and others that are completely undifferentiated. That's what you're going to be calling actually moderately differentiated tumor. Again, while you're doing this, you guys are hopefully end up, inshallah, as clinicians. You're doing it because you're telling the clinician that, this is what I expect the tumor to do. Right, so based on their behavior, right? But also based on morphology, actually. Morphology does play a role in this. All right, so when it comes to, to tumors, it's actually two components for the tumor. The first one is going to be the mesenchymal component. Sorry about that, the parenchymal component, and the second one will be the stroma. So the actual true neoplastic part of the tumor is the parenchyma, which is either the epithelial component or the mesenchymal component that is doing the division, okay? And the stroma is what is, holding this actually component. At one point in time, we thought that the stroma is not important. We thought that the stroma that is, you can see here, is not important. It is simply, happening to be where the tumor is. Now we know that this is not really correct. And that we know now that the stroma is very important to the development of the tumor and also develop for the continuation, for the persistence of the tumor and for the life cycle of the tumor cells. That there is something known as a crosstalk. Have you guys heard this word before? Have you crosstalk? They are talking. The two of them are talking. The parenchymal cells and the stroma are talking to each other and exchanging messages between the two of them. For example, when the tumor cells try to invade, it will be sending emissaries, it will be sending messages to the stroma to help it in this process, okay? Also, the stroma is what's gonna be holding actually the blood vessels, for this tumor mass, allowing it to, to receive supplies. Now, in terms of, broad divisions, there is epithelial tissue versus mesenchymal tissue. If an epithelial tissue give rise to a tumor, it could be benign or malignant. So the same thing with mesenchymal tissue. What you're going to be finding, a lot of difference, when it comes to, the malignant epithelial tissue versus malignant mesenchymal tissue. All right, let's talk about actually how to name a tumor, and I will be asking you how to name a tumor, inshallah, in the exam. So let's say that actually, there is a tumor that is arising from the mesenchyme. Okay, from the mesenchyme, what type of cells do you have in the mesenchyme? You have fibroblasts, you have adipocytes, right? You have the smooth muscle cell, you have bone cells, and you have cartilage. So by adding oma to the, as a suffix, you're going to be able actually to turn it into a tumor cell. So fibroblast, fibroma, and so on and so forth. Okay. Now let's take an example of actually this mesenchymatous benign tumor. It's a tumor arising from an adipocyte. Just by looking at this, again, pathology, as I mentioned to you, and teach yourself that, is the sign of description. So you look at this tumor mass and you will see that it is small. So here is one indication that it is benign. 2, it is surrounded by a capsule, right? 3, it is not really, encroaching or, going through this piece of tissue that is holding it. So there is no invasion. You take a section of, and there is no, also, if you look at this from the surface, even before the cutting, there are no areas of hemorrhage or, necrosis in this tumor mass. All of these are signs that you are dealing with a benign tumor. You take a section of this and you look under the microscope and it will look like, a normal fat tissue, okay, that is surrounded with this capsule. Well differentiated, the most well differentiated tumor that there is. Now here are actually another example of a benign mesenchymal tumors. That's known actually as leiomyomas. These are fibroids. Now these fibroids are going to arise in several locations. For example, they may arise in a subserosal location. They may arise in a myometrial location within the muscle wall of the uterus, or they may arise in a subendometrial location. Depending on where they arise, they may have actually different clinical presentation. At the end of the day, if you look at them, some of them may actually reach large size. So here's one exception to the rule of a small size of a benign tumor. But you will look and you will see that, the capsule is there, okay? 2, you will look at the cut surface and you will not see any hemorrhage or necrosis. And you will see that the tumor is not really encroaching, is not invading. So there is no invasion, which is, like I mentioned to you, is a cardinal feature of malignancy. Now you take a section of this tumor and you look under the microscope and you will see, again, quote unquote, bland features, bland and impressive features. Why? Because the tumor, cells nuclei are all very uniform. Do you agree with that? very uniform. They are not really that hyperchromatic, so not really much cell division happening. It's happening more than normal, but nowhere near what you find, for example, in leiomyosarcoma. And look at the morphology of these nuclei. It's very bland, very spindly, and it does not have any irregular borders. Okay, the size is very uniform and it's pretty small. So NC ratio is really large. NC ratio is really actually small. I'm sorry, NC ratio is really small because the nuclear size is small. Go ahead. These are benign cells, right? Yes. Did I say that is malignant? No, I did not say that. I'm just telling you the comparison between, that the cells here actually look very, benign. If you compare that to a leiomyosarcoma, the cells will be very different. The cells will have a larger nucleus, larger nuclei, and the cells will have, irregular nuclear borders. Okay. The NC ratio of the leiomyosarcomas will be higher because the nuclear size will be higher as well.
They still have a higher NC ratio compared to normal.
Yes. Well, yes, you can say that. Yeah, even though that we don't really discuss it like this, but I think you can extrapolate that as well. But it is nowhere near what you find in malignant tissue. All right, so again, just to show you that pathology, and this is one reason why a lot of people get fooled, get tricked by pathology. This is what attracts them to pathology. They will think that it is a pretty easy. So for example, if a tumor arises from a surface lining or a gland, then you will call it an adenoma. How about that, actually? If it has a cystic cavity, you call it cyst adenoma, right? If this cyst adenoma have mucin in it, you call it mucinous cyst adenoma. How about that? It can get easier than this. And then they get hit actually with, once they get tricked and sucked in, they get hit with the real deal pathology, right? This is actually, it is not really for the faint of heart. I have seen a lot of senior, attendings in histopathology. Do you need the room? Okay, good. Thank you. All right. So actually, the glands, you can see actually that the glands here in this section, this is an example of not what you call not for the faint of heart. You will see that the glands are back to back. This is a scary word for the pathologist. The minute that you start to see back to back with no stroma intervening, that is going to open the door for a cancer diagnosis. So believe it or not, they're going to have fun actually sitting in the office. Thank God I did molecular pathology, and be looking at these glands, and these glands one by one to make sure that all the glands are going to be, are benign and they are not invading or they don't have any cytologic feature of malignancy. Yeah, just to give you a little bit about my background, I'm trained actually in both histopathology and clinical pathology and also molecular pathology. So that gives me a right to actually speak about both, you know what I'm saying? Yeah. Which is bad for both really, if you think about it, because you can tell that I don't hold anything back, All right, what else? Here's another example of an adenoma. In this case, it is a follicular adenoma. This is an example that I just gave you. So, how would you be able to tell follicular adenoma from normal thyroid? Look at this. When you start to see this kind of heterogeneity, large and small follicles, this is normal actually, because normal is polyclonal. Someone asked about this here. Normal is polyclonal. Polyclonal could take, many different sizes, many different types of cell, many different, shapes. So what you're looking at is a polyclonal structure. How about that? You heard it here first. Okay, so now compare this to this right here. Between them, there is this, what looks like a connective tissue that is, embedded with vessels actually, right? And that's the capsule of this entity right here. You look at this entity and the vast majority of the structures of these entities are actually microfollicles. Microfollicles, right? So small follicles. So this is the microfollicular variant of follicular adenoma. Okay, and why is it monoclonal? Right there, from the morphology. You start with the morphology, and the vast majority of those follicles are of a small size, right? Right there, immediately. Okay. Now, what is going to make it actually into follicular carcinoma? This is another actually day of fun in the pathology, lab frozen section. You're going to be called to the frozen section lab, where they will send you actually this follicular adenoma, in a thyroid, okay? And then they will tell you, is it, the question, the differential diagnosis is going to be written like this in the acquisition, it's going to be written, follicular adenoma / carcinoma and a question mark, and you have to answer. So what you need to do, you need to actually take this follicular adenoma and you start to bread loaf it, okay? Piece by piece, and each piece should do the following. Of course, after inking the capsule from the outside, each piece that you cut should contain a piece of this tissue with the adjacent capsule, okay? Because you need to establish what? Invasion. Excellent. So you need to establish invasion. Now, here's the trick, is that this capsule is very slippery, okay? So as you cut, it will actually slip from you, and you will end up actually cutting the adenoma without the capsule, which is not going to be of any use really to you as the diagnosing pathologist. All right, so here is actually another form of tumors, in this case that arises actually from epithelial surface, but have a club shape. These are actually a known entity in epithelial tumors known as polyps. Now, these polyps actually may dangle from a stalk or may lack a stalk, and that's going to be what you call sessile polyp.
Doctor, is this feature only in benign?
Well, there are actually malignant polyps. There is malignancy polyps as well. And the polyps are of different types, as we will see when you go to the GI block. There is, for example, adenomatous polyp. Adenomatous polyp, even the benign one of them, have a chance to become malignant. There is a chance that they may actually transform into a malignant, colonic cancer, but there is also the hyperplastic polyps, okay? There are other types, of polyps that are, in the colon. So for the majority, when you actually talk about polyp itself, you're talking really about an adenoma, and that itself is a benign entity that may become malignant eventually. All right, papilloma is another example actually of a tumor, an epithelial tumor that arises from the epithelial surface. What do you think is the etiology of a papilloma from the name itself? Papilloma. HPV, who said HPV? Excellent. So the human papilloma virus, right? This is what you presume to be the case. Unfortunately, that's not always the case, because some of the architectures that, for example, happen in the bladder may not be related to HPV infection, but you're still going to be calling it a papilloma, okay? Just by, quote unquote, the looks of it. So what does actually a papilloma looks like? If you are using the looks to call certain entities, you need to know how does it look, right? So it does have what you call a complex branching pattern. A complex branching pattern where you are going to be seeing actually a stalk that is surrounded by these, by this acanthotic, tissue. There is a very thick squamous tissue that is surrounding, the core of this branch right here, of this papilla right here, okay? And, the acanthosis and the hyperkeratosis are part actually of this tumor presentation. Where do you see it? You see it everywhere. You see actually, a surface, including, squamous surface, or actually, a surface lining such as, the urinary bladder and other places as well, the larynx and other places as well. Now, when it is arising from an HPV infection, then you will start to see the HPV-related changes in cells. Have you guys taken that? HPV-related changes? No. Okay, so there is no reason to discuss it now. Can discuss it later. Okay, now malignant tumor. How would you? Let's finish this, right? Can you spare me your anger and just a couple of minutes more? Okay, let's finish this lecture. So we have seen how to actually name a benign tumor. Now let's see what the OMA will do to other cells. So it does not really indicate a benign cell all the time. So if you add it to a melanocyte, if you add OMA to a melanocyte, the end result is going to be a melanoma. This is one of the most malignant tumor that there is. Melanoma is known to be a very highly malignant tumor. And if you add it to a lymphocyte, that's a lymphoma. Also, this is a very aggressive kind of cancer. To a seminoma, seminiferous tubules, to a liver, actually, is going to be hepatoma, and astrocytoma, which is tumors of the CNS. And so not every oma means actually benign. It could be something, as sinister as a melanoma. It could also refer to a non-neoplastic lesion, such as a granuloma. Granuloma, hematoma, hamartoma, and choristoma. We'll see what that means in the next lecture. All right, how to name malignant tumors? So for those that arise from the epithelium, you call them carcinoma. For those that arise from the mesenchyme, that's you're going to be calling actually a sarcoma. How would you be naming actually malignant tumors of the epithelium? This is what I'm going to be asking you about. So this is a tribute to you because you're here at 5 o'clock on Thursday, okay? I'm releasing some of the questions right here. How about that? So, first you're going to be establishing where is it coming from? Is it coming from a squamous tissue? Then you will call it squamous cell carcinoma. Is it coming from a glandular tissue? You're going to be calling it an adenocarcinoma, and so on and so forth. From a neuroendocrine tissue, you're going to be calling a neuroendocrine tumor or a neuroendocrine carcinoma. Now, there are secondary description of it. So, for example, if it has a papillary kind of architecture, you simply add the papillary, a word to it. So, papillary adenocarcinoma of the thyroid. So the papilla are going to be both architecture and also it have some cytologic features. You don't need to worry about it now. Medullary tumors, medullary thyroid cancer. This is actually by palpating and figuring out the consistency of the cancer. Is it soft? Then that's going to be actually, you may add the word actually medullary to it. If it is hard as a rock, and that's usually resulting from the fact that there is invasion and desmoplastic response to the invasion, that's what you're going to be calling actually serous carcinoma. So serous carcinoma is going to indicate actually invasion. See, like I'm doing now, I'm taking some of their time now. This is life, one time you're up, one time you're down. All right, and mucinous, if the tumor cells produce mucinous, again, there is what you call a cutoff point. It has to be 75% of the tumor cells that produce mucin for you to call it mucinous carcinoma of the breast. Of course, you don't need to worry about that part, when it comes to the exam question. Here's an example. So you may look at this, and this one looks like an ulcer, right? It's an ulcerated lesion. This is actually a squamous cell that instead of exophytic growth, it decided to dip down. Usually this is what happened in carcinoma in situ. They are usually high grade and they have a high tendency to go deeper, resulting in this ulcerative appearance. Here's another actually cancer that follows, a patient with osteomyelitis, and you will see that the sinus that drains actually the osteomyelitis is going to develop squamous cell carcinoma at one point. So compare this to this one. Both of them are adenocarcinoma. One of them is endophytic, ulcerative. One of them is exophytic to the outside, giving rise to the same type of tumors. We take a section of them. Both of them are going to be looking exactly like this because both of them are well, differentiated squamous cell carcinomas. All right. So here's an adenocarcinoma. That's actually the malignant glands right here. Remember, the gland actually is a 3D structure. The gland does not look like a circle. It looks like a circle only when you cut it, right? In reality, it is what? It's a ball, right? It's a 3D structure. Now, if it has a cystic space, you add cystic adenocarcinoma. It has papillary, you add papillary adenocarcinoma to it. And then there is also mucinous adenocarcinoma. If it's surrounded by mucin, producing intra or extracellular mucin. And if it's it's surrounded with very hard tissue as a result of the desmoplastic response, you call that serous carcinoma. Here's an example of this. One feature that I want to point your attention to is this edges of the tumor. You see these edges? It doesn't look like a knife, okay? It looks what you call jagged edges. Jagged edges. You know what jagged edges mean, right? This is the tip of the knife right here. So these edges are invasive or infiltrative edges. Now, what does the tissue surrounding them do? The tissue surrounding them is going to limit the spread by creating fibroblastic proliferation around those glands, creating what is known as the desmoplastic response. So if you touch this tissue, it will be a piece of rock. Why? Not because of the tumor, but because of the fibroblastic proliferation surrounding them. So this is an adenoid, this is an adenocarcinoma. It does look like an adenocarcinoma. Why? How do I know? Because of the presence of the lumen of the gland. You see that, right? So this is for also, because it's serous, we call it serous adenocarcinoma. All right, here's another gland, where you start to see this multi-glandular lumens within it. This is what we call a cribriform adenocarcinoma. Okay, I will not ask you except actually what is written here. So it will not be, here's another example of papillary adenocarcinoma. You can see the papilla, right? So this is papilla. What's the definition of a papilla? It's a fibrovascular core surrounded by blood, surrounded by epithelium from all sides. Again, it's a 3D structure. So you're looking at only the cut section. And, this actually is associated, with some tumors, including in the thyroid and also in the ovary. Okay, papillary tumors in the ovary, serous papillary tumors of the ovary, papillary tumors of the thyroid, and also of the in the peritoneum. All right, let's stop here now, right? I think you guys are. There's only 2 slides left. We do it next time. I'm done, and you are done too, huh? Fibroblastic proliferation. Fibroblast proliferation. That's right. Attendance. I will put everybody in, don't worry about it. So now I have two sessions from yesterday and today. Okay?
Don't forget because they
And I will do that. I will do that for sure. عليكم السلام ورحمة الله. عندك هدف؟ كيف هدف؟
والله it's from 3 to 5.
Oh, really?
Yeah.
Now it's 3 o'clock.
It's 3. يا ريت 5 o'clock. يعني رحنا تغدينا وخلصنا. الله يسلمك.
This is doing my stuff now. Here's this.
Yeah, well.
معلش اخذت منه شوي من وقتك بس حتى اخلص لك I could not find.
No, it's Yusuf is here regarding the people who did the case report with me.
Who, Yusuf is here?
Yeah, he's here. So I just wanted. I told him Dr. Ouban knows you. He was like, really?
I think I know his name. I heard his name.
Yeah.
I don't know him personally.
Yeah.
That much.